Hi, everybody. Thank you for joining us. I'm Briar Stewart. I'm a senior reporter here at CBC Edmonton. And today we're here for a special discussion on the opioid crisis. It's going to be broadcast live on Facebook. And we've also kind of opened the doors here at CBC so people can come down and participate as well. Now, to introduce the people joining me here today, Dr. Hakik Varani, an addictions and public health specialist, and Petra Schultz, who is a parent and an advocate when it comes to harm reduction and drug policy. So we're going to be having a discussion about the opioid crisis. And if anybody watching online has any questions, please feel free to write in and I'll pose them to our guests. Goes the same in the audience. If there are any questions, please see Terry Reith over here and we'll try to get your question on and answer them as best as we can. But maybe beginning with you, Petra, if I can ask you, how is it that you became involved as an advocate? I mean, what's your personal connection to this crisis?
Well, as I often say, I was not born to be a harm reduction advocate. I too was once a soccer mom. But our youngest child, Danny, he struggled with social anxiety and didn't seek the right care and started to self-medicate, first with drugs that are prescribed pharmaceuticals, although he didn't have a prescription for it. He bought them on the street. But there's sort of that idea behind it, if you use something like a Percocet or OxyContin, that it's safe because it's made by a pharmaceutical company. And he started out using those to deal with this social anxiety, unbeknownst to us. But as OxyContin was reformulated, and at a time there was no help offered to people who had developed a dependence, it was really hard to obtain and also getting more expensive. So Danny and many users like him progressed to street drugs, heroin. First he would snort, and eventually he progressed to injection drug use. And when we became aware, when he came and told us that he needed help, we started a cycle of withdrawal and relapse, withdrawal and relapse. And in the last year and a half of his life, he had reached a stage of recovery. And he was living here in downtown Edmonton. He was working as a chef. He actually lived within minutes of this building. He worked within minutes of this building. To all accounts, he was successful, but he was still struggling. And one time when he relapsed, he wasn't really in the scene anymore. He didn't know what's going on. He thought what he was buying was a counterfeit oxy, but it was in fact fentanyl. And so he overdosed, and I found him in his apartment. That was April 2014. And after, I had not heard of fentanyl before. It wasn't in the news at the time. And what struck me, that at the time when Danny died, there were 10 people dying a month, which seems like a small number now, but it seemed like a lot to me because there were 10 families like us. So I thought, why is nobody saying anything about this? And then there was a case of 10 people in 2 weeks dying in standoff on the blood reserve, and still no health warnings. And I said to my husband, if nobody is saying anything, I think we have to. And that's how I got into it and eventually got connected with other mothers, some of whom are here today, and we are Moms Stop the Harm, a group coast to coast in Canada.
Now, I know you have a picture of Danny there, so maybe we'll get the camera person to pan down and see that. And you're talking about being involved with other moms. When moms reach out to connect with you, what is it that they're asking you, and what is it that you're telling them?
Well, it depends. If it's moms who have lost a child, first of all, they want to tell their story. Our children mattered. And coming out with your child's story and being open about it reduces the stigma, reduces shame. We also provide a lot of emotional support to one another. It's not easy to lose a child, but it's even harder to lose it to substance use because people don't treat you the same. People tell you things like they had choices to make, or a mother in Victoria, a family member told her that, wow, at least there's one less dealer on the street. So these kind of things, we support one another. But I also have parents reaching out whose kids are actively using. And what I tell those parents is, don't fool yourself. It's dangerous. And I talk about safety rules, such as don't do drugs alone and have the antidote naloxone ready, know the signs of an overdose. But I'm quite sure Dr. Varani can provide better information. on that account.
And Dr. Vanni, I mean, how would you describe the scale of what we're seeing right now in terms of, the opioid epidemic or crisis, as it's been come to called?
I don't know that I have the right words, except to say that this is the worst drug safety crisis in North American history. We've never seen anything like this. In Q6 of 2016 in Alberta, looking at fentanyl deaths alone to look at no other drug poisoning deaths, we were losing about one person every 18 or 19 hours in this province to fentanyl poisoning. That's something it's shocking. Since 2011, we've seen almost a 6,000% increase in the number of deaths related to fentanyl. So it's not an exaggeration to say it's never been any worse, but given the way the curve is going, it will get worse.
And I think when people hear that and they know how many people have died and how many families have been affected, I mean, it's startling to hear that. We have a few questions coming in here. One from Facebook Online. Ali Ann asks, what's being done to increase funding and therefore access to basically affordable rehab centers and treatment options for lifelong addicts? I mean, what's being done? And I guess the follow-up would be, could more be done? Is it enough?
Yeah, so I think the answer to the question, what's being done, is not enough. So when we look at deaths, it's always the tip of the iceberg. In 2008, 2009, when they looked at the growing opioid crisis in the United States, the Centers for Disease Control estimated that about 830 people had problems with opioids for every one person who died from an opioid-related poisoning. So if we were to multiply our 343 deaths last year from fentanyl alone by 800, or even 400, you can imagine the scale or the number of people who may benefit from treatment for a substance use condition. We've been talking about increasing the access to treatment by hundreds of people. We need to see increases in the tens of thousands of people to make a dent in this problem, and we've not seen that kind of bold move, unfortunately.
Now, we know today that the province kind of took the next step in trying to set up safe injection sites by talking about where the services would be available. It's just a first step. I mean, how does that help?
Yeah, it's critical. If you think of our first and for a long time, the only safe injection site in Canada, Insight in Vancouver. Even last year, when there were almost 1,000 people died from drug poisonings in British Columbia, not a single one of those people died in a safe drug consumption service. That's remarkable. Not a single person has ever died in a safe injection site. So to be able to offer that service, A, as a way to prevent overdose deaths, but B, as a health equity measure in the inner city of Edmonton is critical. And I think it'll go a long way, not only to reducing overdoses in a population in the inner city, but also to demonstrate that we care. And I think that, with these growing numbers of families who have lost loved ones to a preventable cause of death, to demonstrate in some real way with action that we care is really, really important.
And you talk about the inner city. I mean, we know when we look at the provincial statistics that a lot of these deaths are not occurring in the inner city. They're occurring in the suburbs and the subdivisions. So, Petra, I'm wondering, what you'd like to see more of to be able to, I guess, target and help that population.
When you look at the death in the suburbs, a lot occur because people inject drugs alone. And then again, that is greatly related to stigma and lack of education. We used to address substance use from an education prevention perspective, from a treatment perspective, from a harm reduction perspective, and enforcement. In the last 15 years, almost all our money has gone into enforcement, which means kids don't get any education, we don't do any proper prevention. We are just playing catch up on the harm reduction, and we are nowhere near offering enough treatment. Where we need to start is in schools, for example. In Alberta, we're reviewing our curriculum, and I'd like to see a clear learning outcome in there that drug education becomes part of the curriculum and not the old-fashioned, drugs are dangerous, because we all know teenagers. You tell them something is dangerous, they ask you, where can I find it? And young people, they are in intelligent, you have to treat them with intelligence and give them real information, what substances do, what they do to you, what side effects they might have, what effects they have, and how you stay safe. And it also means that parents have to have an open conversation with children, and that people should not ever do drugs alone. And that anybody who does any drugs these days should have an naloxone kit, the overdose antidote, on hand, because so many other drugs contain fentanyl. So some of those things we can do to keep people in suburbs safe. But, you know, I look at beautiful new health facilities, like we have a sort of a quasi-hospital just outside of Edmonton in Sherwood Park. Why can't we have a substance abuse treatment facility in there where people can go and get on opioid replacement therapy, get education, get training, and offer supervised injection services? You know, this morning in Edmonton, the locations will be announced where Edmonton's first services are proposed, and they are within existing agencies, but I would like to see it become part of primary health care. You know, if I can go get my blood pressure checked, I should also be able to have my mental health and my addictions issues being looked after within primary care.
We're getting a few more questions and comments from online. Nikki Brooks Lucas is watching from Grand Prairie. She just wanted to pass along that her son Dustin had died last February 23rd of a fentanyl overdose. Mark Lambert is asking, you know, would forced rehab save any lives? I mean, is that something that's possible? Is that something that health officials should be looking at?
So, I mean, first of all, we're coming up on the anniversary of a mother's son's death, and that's got to be a very difficult time for her. And to think that there are hundreds of families going through those types of anniversaries and passing through the holidays and having empty chairs at the table, I think that those are folks who would have great ideas about how to deal with this problem at a family level, but also at a public health and policy level. And what we hear from them 201 is that force and enforcement would not have assisted their children or their loved one who's passed away. And that's similar to what we see in public health literature, is that those approaches that integrate patients into care and meet patients with addiction or with substance use conditions where they are, not only physically but also in their journey towards behavior change, is really, really important and a powerful tool to assist them in meeting their goals in terms of overall health and quality of life that they have for themselves. Some people are not quite ready to quit using substances altogether, but they would like a safer environment to do so. They would like to know about what options exist, but they don't want to be thrown in jail and forced to dry out, so to speak. The additional medical downside of doing that is to force people into abstinence-based recovery programs. Not only doesn't increase their rate of abstinence to follow, but it also lowers their tolerance to drugs like fentanyl or opioid drugs. And after a prolonged period of abstinence, when they relapse, if they do, and you know, in excess of 90% of people will relapse shortly after they leave jail or a residential treatment facility, their risk of death is actually higher than if they had never gone in the first place. So we spent thousands of dollars on an admission that was not only ineffective, but also may have done them some harm, and may have increased the likelihood that they either die or require an expensive emergency and possibly hospital admission and interventions in those places that did nobody any good. So I think it would serve us well to listen to the moms like the one who commented on Facebook, and to Petra, who are people who have spent no shortage of time thinking about this problem and know the points in their children's histories where change could have been made.
And you know, following up on your comment, Petra, about education, we have another question here from Jessica Chan asking, what can we do to educate students on opioid addiction? Is it too early to start talking about this in junior high?
Not at all. Actually, junior high, early junior high is the latest when we should talk about it, because once research shows once you have somewhat entrenched drug-seeking, drug-taking behavior, it is far more difficult to make any changes. And one thing young people need to learn, the peer environment. There's a time when the family environment becomes less of an influence and peers become a greater influence. And it is important to have young people understand how to deal with with the influence of the peer environment if there's something they don't feel comfortable with. Sometimes kids get into things because they're afraid they might lose friends. So all these kind of skills we can teach, and we have to teach them at an early stage. But I also want to add to the point earlier in regards to rehab. There is sort of the myth that for somebody to deal with their drug dependence, they have to go to rehab. The stories that our mothers share, their families that have out of their own pocket remortgaged their houses, spent thousands and thousands of dollars on rehab only to spend thousands more to bury their child. There is a mother in Vancouver who's a member of our group, Michelle Jansen. Her son Brandon died in rehab, and the coroner's inquest just completed 21 recommendations that should improve. Rehab is an industry. There's no regulation. I could open up a rehab center tomorrow. I don't have to be a nurse. I don't have to be a doctor. I don't even have to have a university degree. I just have to have people who are willing to give me money and send me their children. And and while there are some centers that show good outcomes, there are some where the outcomes are really not very good.
When people are desperate and trying to get their child or their loved one into a rehab center, space is always an issue, and so is the financial cost. We have a comment here, a question actually from Mark Hudson, and it's sort of a double-barrel question, I guess. He's saying, shouldn't medical marijuana be prescribed and in turn reduce some of the use of opioids? Because we know opioids are prescribed at such a high amount. Canada is I think the second largest per capita user of prescription opioids. I mean, how do we bring that down?
Yeah, it's true. We jockey with the United States for first place, and it's a dubious distinction to have. And third place is typically Denmark, which is about 150% behind Canada and the United States in terms of the per capita opioid consumption. So we have a problem that may have been part of the genesis of this entire crisis in the way that we practice medicine around the treatment of chronic pain conditions, where we prescribe lots and lots of opioids in conditions where we haven't really studied or could have confidence in the benefits from those prescriptions, and we know a lot about the harms of those prescriptions. It's also pretty undeniable that those jurisdictions that have more permissive marijuana policy, including medicinal marijuana policy, see lower opioid prescribing in general, and also lower harms from opioids in general. So I think that's something that ought to be entertained, and Canada is moving down a direction where marijuana policy will become more permissive. Mm-hmm. And we're certainly learning more about the use of cannabinoids in the treatment of medical conditions, including chronic pain. So that's part of the big picture. I think that the other part of this equation in terms of how we prescribe opioids must recognize that there is a large number of people on high doses of opioids already. And the knee-jerk response would be, well, if we're in a crisis, we better dial back those prescriptions. That can also be dangerous. So every patient on chronic opioids who's been taking them for a long time in high doses will have tolerance and dependency to those opioids. Whether or not that's morphed into an addiction disorder with social dysfunction is a slightly different story, but to remove them from opioids entirely is almost a sure recipe to make things dysfunctional. Mm. And so my colleagues and I have to be very careful about doing that. I have a colleague in Ontario who's fond of saying tapering opioids is a marathon and not a sprint, and we ought to treat it like that. And recognize that every patient presentation is legitimate. You just have to peel the onion and understand what the situation is. Where opioid guidelines and prescribing guidelines become very important, though, is in not starting chronic opioid therapy where it's not appropriate in new patients with injuries and with chronic pain conditions.
Not making it the first choice in terms of pain management.
Right.
Now, following up on that, Amy Graves has a question. How is Alberta preventing unnecessary exposure to prescription opioids? Because I think it's important to point out that when we talk about the opioid crisis, there's two things going on here. I mean, there's the prescription opioids, but we're also talking about illicit drugs coming in some cases from China, fentanyl, carfentanil. But when it comes to prescription opioids, what is Alberta doing to, prevent unnecessary exposure?
Yeah, so it's a good question from Amy. And again, this is something that, the answer to the question, how much are we doing for addiction treatment, is not enough. And the answer to the question, what are we doing to address opioid prescribing, has to do with how late we are in the game. This has been a problem that's been going on for decades. And we've seen the numbers of opioid prescriptions, the number of people on high doses of opioids, and the amount of time that people are on high dosages of opioids going up over decades. And that's very much related to how opioids have been marketed in North America and how physicians have been educated by big pharma to prescribe opioids without a real appreciation for the amount of risk that's involved. And we're now seeing the manifestation of that risk. The rub, though, is that our most developed interventions in this crisis have to do with prescribing. And all of the answers don't sit there. Because as you say, the demand for opioids is now also being met by these illicit, extremely toxic bootleg versions of fentanyl and fentanyl analogs that are the dominant opioid in the street drug market now. There's an unintended consequence of dialing back opioid prescribing, and that is that there are fewer prescription opioids diverted onto the street, and the demand is then increasingly met by the illicits which are more dangerous.
These covert labs that are making different pills and crushing things.
Absolutely. No quality control, no quality assurance. And people who are using those substances don't know what they're getting and how much of it. So our answer to questions around opioid prescribing must be that we have to practice good medicine in our examination rooms, assess the patient well and examine them, and choose those options that will benefit the patient most with the least amount of harm. But in the public health picture, if we're addressing opioid prescribing, we must, at least at the same time, increase access to treatment for people with substance use conditions and make safety measures like harm reduction extremely available for people who are using other substances which will increasingly be more dangerous if the supply of prescription opioids comes down.
Thank you. And just for those watching, again, this is a kind of a special CBC Live, Facebook Live discussion on the opioid crisis. If anybody's watching in the mall here and would like to ask a question, please see Terry over here, and he'll bring your question forward. We're getting more questions here online. A question from Eric Anderson. Could the panelists please address the condition and needs of Aboriginal populations in regards to opioid abuse? This is a huge epicenter of the crisis. So who'd like to begin?
So First Nations communities are very dear to me, and I think similar to inner cities, while we're seeing a lot of deaths outside of the urban cores, and while we're seeing a lot of deaths not on reserve, those populations that experience health and social inequities tend to be the ground zeros of crises like these, whether it's an infectious disease crisis, or whether it's a chemical hazard crisis like fentanyl and our prescription opioid crisis preceding that. And it is no accident that the first public declaration of emergency that was made was in standoff. And Blood Tribe was experiencing the manifestation of social and health inequities with high numbers of people on large opioid prescriptions preceding fentanyl, and they were the testing ground. I would say throughout Canada, they were the testing ground for the fentanyl market. So public health on reserve is a federal jurisdiction. The federal government needs to step up and make treatment available for people who are living on reserve, and First Nations living in inner city as well. They face tremendous systemic discrimination in healthcare. And add to that if they have trouble with substances, they have an additional strike against them and another reason for people to stigmatize. We need to start getting over our differences and treating human beings like human beings, and I can't think of a better example of where that's necessary than with our First People.
And if you look at the First Nations population, we have people living on reserve, but of course many First Nations live in the city. And the proposed supervised injection services in Edmonton, there was an extensive research study done by Dr. Elaine Hishka to prove the need for these services. And she interviewed people who were using substances in dangerous ways, sharing needles, injecting on the street and such. And she found that over 65% of those identified as Aboriginal. So we have to have services for Aboriginal people on reserve, but also in the city. I also think maybe on reserves we have a unique opportunity. I recently read about a study in Iceland where they have dialed down drug use and alcohol use of young people by an astronomical percentage. I don't remember the actual number to quote it, but it was very, very significant. What they did is offer young people alternative. And I'm thinking with some of our Aboriginal communities, especially ones that are struggling, being so isolated, why can't we take an opportunity and you see it as an opportunity to inject mental health services and giving alternatives to young people, giving them activities, employment, education, opportunities, and address the issue that way.
And so you basically keep them busy so they're not necessarily looking for other things to do out in the community.
And not just keeping busy, giving them hope.
Mm-hmm.
You know, I think a lot of, especially young people in Aboriginal communities, they don't have any hope. And there are studies that show the connection between substance use and the lack of hope for the future.
Very, very good comments. We're getting lots of discussion and comments online, but I did want to take one here from the audience. Hi, DJ Padamadan. Okay, sorry. I'm sorry that I pronounced that incorrectly. So you have a question? Please go ahead.
Yeah, there are several opiate-like substances that are unregulated in the market, one being a substance called kratom. I'm just wondering, what is the regulating bodies in Canada going to do about unregulated opioid-like substances?
Yeah, so there's certainly anecdotal stuff where people using kratom use it to try and wean themselves off of opioids, and no shortage of social media sites that or users who describe that experience. I think in the broader picture, the criminalization of any substance has not been a successful way to get people to stop using those substances. That goes for kratom, it goes for heroin. People have been using substances since the beginning of recorded history. And all signs point to people will continue to use substances. Criminalizing those substances does not reduce the chances of somebody using them, but increases the marginalization of those people who do. And so if some people have access to kratom and decide to use it and get caught with it, they shouldn't go to jail. And the same goes for marijuana. I would treat it in much the same way. I wouldn't go as far as to say people should get their hands on kratom to try and wean themselves off of opioids. There's not good medical evidence that that's something I should advise. But I do think there's good public health evidence that criminalization of any drugs, including kratom, is bad public policy.
And it's interesting because you mentioned heroin, and we know that in BC right now there are some calls from some in public health to talk about prescribing heroin, so you don't have people trying to get drugs on the street. Another question online. Thanks very much. Did you have an additional question? Great. Thank you, DJ. Wendy Wood is watching online on Facebook. She says, as a pharmacist specializing in psychiatry and addictions, I wish that our pharmacy schools had much more addictions training. There's little, if any, now. We're at the front line of recognizing substance abuse, but we don't know what to do when we see it. We are put in the role of policing rather than being healthcare professionals. We can help with the slow tapers as we can because we see these patients every day. So a comment from a pharmacist. Thank you, Wendy. And Deborah Watson wonders, what about the role doctors play in addictions? My son was prescribed 10 8-milligram oxys per day plus 20 milligrams for breakthrough pain daily for 5 years, then cut off, and people wonder why addicts go to the street for their drugs.
Yeah, so, that's a common story, unfortunately. I think that as a profession, we've sort of lost respect for these drugs. Because we've seen higher and higher doses prescribed for some patients, we think that all patients who are prescribed opioids can tolerate and not be harmed by those high doses for long periods of time. But we know that that's not true. I think the risk of how much heat there is on this discussion is, as I said, a knee-jerk response that, well, we ought to treat these statistics, and if our prescribing is too much, then let's make our prescribing a lot less. And unfortunately, the manifestation of that is, a young person who's on high dosages of opioids being cut off all of a sudden. What do we expect would happen, but them trying to access that elsewhere? When we understand what the medical implications are of chronic opioid exposure, being tolerance, withdrawal when it's not there, and addiction being a common side effect. So I think that, as I said, we have to practice good medicine, and that goes for increasing dosages of opiates, starting opiates, and also stopping them. We have to do that wisely.
I I also think that as patients, we have a role and we have responsibilities. When post-operatively, for example, if you get a prescription for an opioid or for chronic pain conditions, patients could ask, do I need all these? Can I get a smaller prescription? Can I get something for 5 days and see you again, doc, if I think I still need it? You know, nobody should walk out of their doctor's office with 150, 200 opioid-based pain medications on their prescription without proper follow-up. But as patients, we can question that. What we also need to do is we have to check our medicine cabinets. I give talks to nursing students and I ask them, who of you has been, or I can ask the audience here, who has had any medication that they've taken, like an antibiotic or something, and after you were done, you've immediately taken the rest of the pills back to the pharmacy. And you have a small minority of people raising their hands. And that's what we should do. You know, that's how they get out on the market. We should take less, and it's okay to question your doctor, I think. As a patient, you have rights. You should question your doctor and say, do I need this? If you don't, and it's a matter of health policy as well. In Alberta, we come close to cutting off coverage for physiotherapy. Physiotherapy is one thing that can help lower the use of pain medication. You know, if people have hip, knee, back pain, physiotherapy can help. But instead of putting health policy where we reduce the risk, we give out as many OxyContins as anybody wants. But if you want physiotherapy or any kind of alternative medicine, it's much harder to get. And that is a problem in our health policy drives people into opioids, and that's wrong.
Here's a question from Anne-Marie Spruill. She asks, do you have any advice for parents that are starting to see signs of substance abuse in their teens?
I would say talk to them. Don't ignore it, but try to have an open conversation. You know, often when we become accusatory or threatening, young people will just close off and we will not get the information. So have the same kind of conversation we have about drinking and driving, because we never assume that none of our kids will ever drink at a party, but we hope they don't drive. And that kind of information we have to have about drug use. Talk about safe drug use. What I tell the nursing students, I don't say if you take drugs, I say if you know anybody who might be taking any drugs, here are safety rules that you should follow. So I would focus on the safety first, because by focusing on the safety, you tell your kids you love them no matter what. You open up the conversation, but you also say it's serious. They're good website. BC has better websites than Alberta on the topic. But if you Google drug safety BC or fentanyl BC, you find good information, and that opens up a dialogue. And then have a real conversation without the stigma and without shutting them down.
And I think the other thing that's important to note is, you know, what's so alarming about this crisis is if people are buying things on the street, they're getting fentanyl when they think that they may be getting something else. I'm wondering if you can kind of elaborate on that.
Yeah, so that's a real thing. People who think that they're getting methamphetamine on the street, it is very likely cut with fentanyl. I would say that about half of the toxicological samples on patients who give a urine specimen for drug screening who think that they're only using methamphetamine will also come back positive for fentanyl, and it's scary for them. Patients or people with substance use problems who are using cocaine, or people who are recreationally using cocaine, have also likely come into contact with fentanyl. And we certainly have heard stories, including of couples who die and are found by their young children who are recreationally using a stimulant like cocaine, which people do, and were found dead, having been exposed, unbeknownst to them, to fentanyl. So we likely wouldn't have fentanyl in our market if we had a decriminalization of drug use for personal use. We likely wouldn't have seen fentanyl if we met the demand from increasing opioid addiction early with treatment. But here we are now. And what we need to do is try and apply good evidence-based public health and public policy to offer treatment for people who are struggling with substance use, to provide safe places for people who use substances, including non-opioid substances, to use them, and make sure that people are equipped with take-home naloxone in case they either knowingly or unknowingly are exposed to an opioid and experience an overdose.
And we'll get to the take-home naloxone in a moment because we do have a kit here. So anybody who's watching Facebook online, we're having a special discussion on the opioid crisis. Anybody watching in the City Centre Mall area here, if you have a question, please see Terry Reith over here and he can bring your question forward. Dr. Varani mentioned the take-home naloxone kits, and these are kits that you can pick up at most pharmacies. We have one here, and I'm wondering if you could maybe just, go through it and show people that if they were to pick up one of these kits, this is what would be involved in using it.
Sure. So in the kit, there's a number of components. All of them are important. One of them will be instructions on how to use it, and it's very simple. So anybody can get trained in how to use this, and you're not required to be somebody who uses opioids to be able to pick up one of these kits. The best public health evidence is that if you're in a population where you may come across somebody who's overdosed on an opioid, you should be able to get a naloxone kit to help them. So if you did come across somebody who appears to have overdosed on an opiate, and the signs of that might be a change in color, so that there's no redness. They may be cyanotic or blue on the lips. They may be pale. And you'll see that their breathing is shallow or absent. What you can do is first stimulate them to try and wake them up, call their name, yell, rub on their chest to give them some discomfort and see if they come to. If they don't, you want to establish an airway for them. So you tilt their head to make sure that if there's anything obstructing it, that's moved out of the way. You will give them a rescue breath with a non-rebreather mask that is here, and it shows you how to do that. And then you reassess and see, have they started to breathe on their own? Are they responsive? If they're not, that's when we can administer naloxone. So an ampule of naloxone looks like this. And you'll draw it up in this needle, the full contents of one ampule. Then you'll hold it like a dart, and you'll insert it into a large muscle, like a thigh, is usually where people would do it. All along, just remember that we also need emergency services on hand. So calling 911 is critical, especially with the more and more toxic opioids that we're using, that people are using. A person who's rescued with naloxone will still require emergency care, very likely. There's 2 dosages of naloxone here, and you may need to use both in one single overdose episode. And that still may not be enough depending on what opioid has been administered.
If they took carfentanil, for instance.
If they took carfentanil, for instance, we might expect that they'll require increasing doses of naloxone. It'll depend on how much. Mm-hmm. So because there's so many unknowns, 911 is critical. And I think our first responders have done a good job in making sure that it's understood. If somebody is, if they're called to a scene where somebody's overdosed on drugs, the preoccupation is saving the life. Nobody should be thinking about criminal charges, including of the person who called, even if they were using drugs or had sold the person drugs. The first preoccupation should be saving that person's life and then getting them help afterwards.
And I think for anybody who would perhaps be in a situation where they may, be thinking about maybe they should use the naloxone kit if they come across somebody that's unresponsive, is even if it's not an opioid problem, there's really no effect of using the naloxone.
Yeah, there's very, very, very few situations where administering naloxone in a case where it's not an opioid overdose is going to do the individual some harm. And that's why public policy allows for take-home naloxone to people who are not, to be administered by people who are not health professionals.
Right. Okay, just back to the online questions here. Rhonda Gray is asking, would it not be more cost-effective to give out kits that chemically react to fentanyl? They do exist. That way people have a sense of what they're taking.
Yeah, so one of the harm reduction interventions that's being explored and has been used at places like Insight in Vancouver is drug testing. So know your source and know what you're using is pretty good advice. So I think that's something that is indeed cost effective, as the person commented, and also may benefit the individual to take more safety measures or precautions if they're using. But what we also know is that people who have trouble with opioids, who understand that what they're taking is fentanyl, may still feel a compulsion to use it. That loss of control it typifies an addiction disorder. And just so that people understand, the characteristics of an opioid withdrawal are severe. People are extremely uncomfortable when they're in opiate withdrawal, and they're extremely uncomfortable knowing that it's coming even if they're not in it yet. The best I've heard it described is it's like the flu times 100, where every orifice of your body is running with fluids. Your eyes are running, your nose is running, you've got uncontrollable diarrhea. Every muscle in your body hurts. You've got hot flashes, you've got cold flashes. You can't hold a pen straight because you're tremoring so bad. And the cravings that people describe are so intrusive, where it doesn't matter what they're doing, they can't stop thinking about the next administration of that drug. And this is not a characteristic of people who are weak-willed or immoral. It's the way the human brain responds to chronic exposure to opioids in some people. And so even if they know that what they're using could kill them, they may still use it, and that doesn't make them stupid. It makes them human. And I think we all should recognize that this is not an act of volition in every case. There may have been a bad decision somewhere along the line, but when somebody's in the throes of addiction, I think that it's safe to say every one of us in that position would probably use and take the risk.
After Danny died, one thing we heard from people, well, he had choices to make. And if you think about choices that impact our health, I think about that every time you hear about somebody taking their snowmobile into the backcountry when there's high avalanche danger. They trigger an avalanche, they get buried. We don't stand on top of that pile of snow and say, bad choices. No, we dig them out. And if they die, we say, wow, they died doing what they loved, whereas there was an element of bad choice involved. So we have to get over that stigma, over blaming. We are blaming the person who is not in a position to change what they're doing without help and intervention. We are withholding the help, we are withholding the intervention, but yet we blame the person. Which has brought us to the crisis that we lived in today. Our group, Moms Stop the Harm, started with 3 moms last April. We're not even a year old. We are now over 100 people, moms, sisters, spouses, mostly in BC and Alberta, but all over the country. And with every person who joins, with every story that comes, there is a tragedy, there's a family in mourning, there's a family grieving, and I cannot imagine another health crisis where, as Dr. Virani said, it's one of the greatest health crises we have faced in this country, and we are not taking the action that is really needed.
And carrying on that thought, we have a question from Torch Rankin, wondering, do the panelists feel support and energy from the government is enough? Is there a sense of urgency being met when they seek resources and support?
No, I don't think so. I think that, in British Columbia in April of last year, the Chief Medical Officer of Health and the Minister of Health declared a public health emergency. That was an outward demonstration of how serious they recognize this problem to be. It needs to be followed up with some very definitive actions, which I think are, underway in some provinces. But the refusal to declare a public health emergency in Alberta, I think, is problematic, because our governments have unfortunately demonstrated that, in spite of the best efforts that they're putting forward, the problem is getting worse. And public health emergency declarations are available to us to assign extraordinary resources when the ordinary resources and measures fail. They've failed, and they continue to fail. When we're losing one person from fentanyl alone every 18 or 19 hours in this province, and when there are ripple effects to families, to emergency departments, to morgues, to every aspect of social endeavor that you can think of, no, there's not been a demonstration that we care about this problem. I mean, it strikes me that today, we sent our kids out the door to school in pink t-shirts because it's National Anti-Bullying Day. And what we told them is this is about being respectful of people's differences and having compassion for people who are struggling with stuff, being there for folks. But on the other hand, in our policy jobs and in our healthcare jobs and in government jobs, we are sometimes indifferent when we don't identify with the situation. So as Petra said, there are so many decisions we make about personal health behaviors that result in chronic diseases and such. We build entire institutes and hospitals and research infrastructure to support, cardiovascular conditions that oftentimes have a lot to do with what we did to ourselves. Of course I wish that nobody used substances, just like I wish that everybody exercised and everybody ate fruits and vegetables and nobody bungee jumped. But that would make for a pretty bland society. And our job is to be there for people regardless of what decisions they made about their own life when it affects only them. And that's not just a philosophical position, that's also a practical position. Societies that do that and healthcare systems that do that have people with longer lives who are more productive, and we save money in our healthcare system and outside of it. So to me, this is, for us to commit resources to this problem will ultimately save us money and be reflective of Canadian values.
And I know in a previous interview that you had with CBC, you compared it to the flu epidemic, where when it's flu season and the rates are really high, you see just how many resources are thrown at that, and then here it's a little different.
Yeah, so if you take a look at the numbers during the pandemic, right, the epitome of public health intervention, the number of people who died from H1N1 compared to the number of people who died last year from fentanyl alone, we still don't know how many people died from prescription opioid and other drug poisonings. It doesn't reflect the same understanding of, or the same value of human life. If this was an infectious disease crisis, we would see assessment tents and buildings be set up all across the province for 24 hours a day, 7 days a week, until we had this thing under control. We do not see that bold of a move from frankly anywhere in the country, but certainly not Alberta, to increase access to treatment for people who are struggling with substance use disorder. And while we're encouraged that we're looking at safe injection services in the inner city of Edmonton by the end of this year, if you look at the pace of fentanyl-related deaths, we're going to lose hundreds of people by then. Wow. So we need urgent solutions that are evidence-based. It's not like we have to do something novel. Petra's discussed the interventions that would turn around the death toll, or at least shift the curve. We can do those things with committed resources.
There's a question I want to get to online because a few people have asked it now in different ways, but this one's from Eric Anderson. He's wondering, would implementing a similar system to Portugal's decriminalization of all drugs and more mental health and rehab support be useful here in Canada? And I know that what Portugal has done has been in the news lately, and so it is very, very topical.
What Portugal has done is really quite amazing, especially if you consider that it is a country that economically is not as wealthy as Canada. They have used their limited resources and put them where they work best. So they have not only decriminalized personal possession of drugs for personal use, and we have to understand, a lot of people don't understand the difference between decriminalizing and legalizing. Legalizing, like cigarettes, alcohol, they're legal. We can buy them, there's nothing wrong. People abuse cigarettes and alcohol, but they are legal. Cannabis, most opioids that you would buy on the streets, they're illegal. But if you take an approach where we decriminalize, we say, okay, we don't throw you in jail if we find you with an amount for personal use, and they go by a number of days in Portugal. But what they also do, they also offer people access to treatment. So decriminalization alone would not have achieved the results they have. They give people options and alternatives like opioid substitution therapy and other measures. And we have to redefine how we understand the person being in recovery. If recovery is the person being substance-free, that is achievable for some, but for many people it's not achievable. For me, being in recovery is not having to chase your daily hit and having to face an overdose. If you can get heroin on prescription, if you can get your medical substitution therapy, you are in recovery. You're living again, you're functioning, you have quality of life. So we have to really redefine what we aim for, support people. And we have some steps towards decriminalization. There's a 911 Good Samaritan law that has passed the House, that is before the Senate right now, that will not make it a criminal act to be in possession of illegal drugs in case of an overdose. dose. So that's a tiny step into the direction of Portugal, but that is decriminalization. The dealer, of course, that goes around with pockets full of stuff to sell, that's still going to be illegal. The guys that bring the stuff in from China, make illicit pills, and make millions, we would like those locked up, and that is still illegal.
Right. Here's a question from Cole Willett, and I think he's following up on what you were saying, Dr. Varani, about, if this were a public health crisis like SARS, the federal and provincial government would have no hesitation declaring a public health emergency. He's wondering, what is the medical community in Alberta and across Canada doing to make this an immediate political issue?
I've been impressed by the leadership from our College of Physicians and Surgeons who, in their area, are making moves towards addressing a prescribing problem that we've had for decades amongst my profession, but also publicly endorsing harm reduction, including safe injection sites, as a critical and necessary measure to assist in addressing this crisis. There is a recognition on the part of our medical regulatory community that, trying to dial back the prescribing is not going to solve this problem and may, in and of itself, make things worse if it's the only thing that we do. So I think that leadership has been good. I think we could do more. I think that as a profession, the way that we approach patients with addiction would go a long way to destigmatizing and to demonstrating that we care. I think that reflecting substance use education in our medical curricula would also go a long way to sensitizing healthcare professionals to the particular needs of people who've run into trouble with substances. But I think that we all need to be more vocal. We all need to be more demanding. The people who are capacitated to make public health decisions in this province are also doctors. I think that it's okay for us to remind them that we took an oath. And when you're a public health doctor, your population is your patient. And our first priority and our first preoccupation should be with them. And that may sound soapbox, but in a healthcare profession, it's really not.
So why is that not happening?
Well, I actually wrote on this last year. Your commenter brings up the SARS epidemic. We did not perform well during SARS in Canada. And there were no fewer than 4 commissions post-SARS that said that public health is broken in Canada because the decisions are not made independent of extraneous considerations like what government has to be preoccupied with and like elected officials have to be preoccupied with. Public health needs to be independent of that. Their singular contemplation should be what is in the best interest of human health and of human life in this case. Unfortunately, we have kind of extraneous thoughts about, well, what's the resource situation? We're in an energy-based economy. How can we spend this kind of money on people who don't vote generally and that most people don't care about? Well, as a public health doctor, they're a part of your population. We've lost thousands of them during this epidemic. We have to behave like doctors. If we had an emergency at the bedside, we wouldn't strike a working group and decide for a year, what are we going to do with this person's grocery bill? Because they wound up in the hospital with a myocardial infarction or heart attack. We would stabilize the situation based on good evidence, investigations, and an examination of the patient, and we would save the life. And here we have a population where mountains of people are dying, and we have to stabilize that situation with what we know in public health to be effective.
So carrying on that thought, a question from Torch Rankin. He's wondering what the panelists think that this province, the people and medical professionals should do, and legislatures specifically, in the next 60 days to try to make a difference in this crisis.
What we should do immediately is declare a public health emergency, not only in Alberta, but Canada-wide, and put the resources in. We've done well on naloxone distribution here in Alberta, although there's still room for improvement. But why do people have to overdose in the first place? We have to prevent those overdoses from happening. Don't get me wrong, it is important. But what we need to do is get a sufficient number of physicians that can put anybody who is willing on opioid substitution therapies the moment they're willing. Right now, people have to wait a week, have to wait 2 weeks, have to wait several weeks, have to wait months, depending where you live. You have to, when somebody struggles with substance use, you have to meet them where they are at. You don't know where they will be in 2 weeks or 2 months, or if they'll even be alive. So there should be the availability immediately for everybody in all communities. So it has to be deeply embedded in our primary healthcare system. And in conjunction with that, we should offer a psychological counseling to people. Psychologists are not covered. The time that brought our son recovery is when which we fortunately were able to do, paid privately for psychological counseling. That in conjunction with opioid substitution is what helped him and could help many others. It didn't help him in the end because we didn't know enough of how it should work, and that you have to be on it for a stretch of time. But that information has to be out there, and we have to offer it in the reserves, in cities, in the country, and within our correctional system.
Yes, and hopefully this helps in getting the information out there. We have got quite a few comments online, not so much questions, but people who wanted to say thank you very much for your information. They were very appreciative. Some people were talking about how they are in BC and they're struggling to get into treatment. Others talking about how they're on opioids for chronic pain and are trying to get off of them. So certainly a lot of people watching along and engaged. Now we'll wrap this up very shortly, but I'm wondering if there's anything you'd like to add that you thought we didn't touch on about what we can really do to address this.
Yeah, I'm struck by the previous question that it's asking for solutions in the coming 60 days. And, those are not the windows that governments typically think about. But that's the window of time that we ought to be operating in, is days and weeks, not months and years, to solve this problem. To me, there are some critical evidence-based interventions that need to be offered in large proportions to be able to solve this problem. One is, as Petra said, rapid access to opioid replacement therapies or opioid agonist maintenance therapies for people who are struggling with substance use. And we're not talking about increasing spaces in clinical programs by tens or hundreds. We're talking about tens of thousands of people getting access to that if they want it. And so that means, mass clinics that operate day and night, so long as there are people who are presenting for care. Supervised drug consumption services need to be established quicker than by the end of the year, and not just in Edmonton, and not just in the big cities. They need to be offered everywhere, and as Petra said, as part of providing primary health care. We don't necessarily need specific sites dedicated to this, but when people present for health care and they have a problem with substance use, our job in healthcare is to reduce risk from any condition, including substance use conditions. We need to continue to expand naloxone distribution programs with more touch points for people to access them. Physicians and pharmacists need to never be barriers to people accessing naloxone, and there's unfortunately stories of pharmacists who refuse to provide naloxone to patients based on moral grounds. We also need to do a better job of conducting public health surveillance on this problem. Reporting on it every 3 months and only reporting on fentanyl poisonings is not enough. We need to know what's happening with drug poisonings, period. And we don't just need to know about deaths. We also need to know what's happening in emergency departments and in other touch points in healthcare. We need to know about what drugs are being seized by police. We need to know what the trends are in drug use amongst various populations. And that needs to be ready in real time so that we can respond in real time. And then something that's not quite a 60-day solution, but shouldn't be much longer than that if we do things right, is to decriminalize drug use. If there was just one intervention that we could do, and had we done it a year ago, we might not be in this position. It's decriminalization. We're not talking about going as far as to legalize all drugs. But what we're saying is that when people struggle with substance use conditions, or if they recreationally use drugs, the appropriate intervention for them might be to provide treatment if they have a problem with them, but not to throw them in jail. That provides an incentive for drug traffickers to make drugs easier to traffic, which brings us things like fentanyl, carfentanil, and probably other things if we don't get this right. So to me, those are the list of things that we ought to have done in 2012, 2013. But it's, we saw over 300 deaths from fentanyl last year. If we don't want to see more next year, then those are the things we have to do.
Okay, we have a question here. We have a question here from Ron Bereznicki. Go right ahead, Ron.
Hi, my name is Ron Bersnicki. I have like missing cartilage in my hand, and I'm a chronic pain sufferer, and I'm on Dilaudid, which is pretty, and I really need Dilaudid because the pain is really out of control sometimes, and like my question is, because of all this pressure for fentanyl and overdosing, then there's pressure on that's transferred over to legitimate chronic pain sufferers, and what reassurances do I have as a chronic pain sufferer that I don't suddenly get pressure on me to have my pain relief reduced? Like, there has to be some way that, sure, I understand that fentanyl is a crisis, but let's not throw out the baby with the bathwater and deny pain relief to those of us who actually do need pain relief. So my question is, what assurances do I have as a chronic pain sufferer that I won't be swept up and and have trouble getting my prescription for a legitimate need that I have?
Thank you.
No, it's a great question, and I know that there are many people in that situation. My sense is that in preparing guidelines and an approach to opioid prescribing in Alberta, our College of Physicians and Surgeons is sensitive to that scenario. That's my sense. And that the press is not to try and change the statistics per se, but to practice better medicine. And if in a particular situation, the right call is to continue to prescribe high amounts of opioids for a chronic pain condition, and if the physician is monitoring the effectiveness of that treatment, mitigating the risks of that treatment, and balancing those correctly, and is in some cases trying to make an attempt to lower opioid dosages and see if that makes a positive impact. I can't tell you how many people actually feel better as we bring down dosages of opioids, but some don't. And so the physician has to recognize that they must monitor pain control and function and quality of life in every decision that we make medically. Chronic pain is no different, and neither is substance use. I mean, they're all legitimate presentations, and we have to practice good medicine. I think our college gets that. But the key is to make sure that physicians in their exam rooms practice that way.
Great, and I think that's a really good, point to make here at the conclusion of this, because as we're talking about the opioid crisis and addiction, there are people who are prescribed it because they have chronic pain, and this is how they cope with that and manage their pain. I want to thank everybody online on Facebook for watching, and thank you for your comments and your questions, and everybody here in City Centre Mall as well, and of course Dr. Virani and Petra, thank you very much.
Thank you.
Thank you.